We're at the IAS meeting. We're here with Carl Dieffenbach, who's Director of the Division of AIDS in Washington, D.C., and actually Bethesda, Maryland. And we appreciate you taking the time with us again to talk about vaccines and prevention here at the IAS meeting.
Thank you. It's a pleasure to be here. I do enjoy sitting down with you at each of these meetings. This meeting's been really interesting in terms of the data that has come out, particularly in the HIV vaccine area. With the RV144 trial that was first reported in late 2009, it showed a very small but modest level of efficacy. And from that signal, we've been able to build a set of hypotheses for why that vaccine worked. And in so doing, we then took that existing Thai-based regimen, which was based in B and E clade epidemics, reworked it to a C clade vaccine, added an adjuvant, MF59, which is supposed to give greater durability, and then came to sub-Saharan Africa, in South Africa, to first test the vaccine to see if it behaved and performed as we wanted before initiating a very large efficacy study. So that has been the goal. So at this meeting, we reported for the first time publicly the data from HVTN 100, which was all about this testing. And not only did the vaccine hit its marks, it exceeded its marks to a point where come November, we intend to initiate a large proof of concept efficacy study called HVTN 100 here in sub-Saharan Africa. We're going to enroll about 5,200 people. So it's a really major milestone for us. So that's the main news that we have to report clinically. There's also at this meeting a fair amount of energy and effort going into discussions around broad neutralizing antibodies. As we heard yesterday, the AMP trial, the antibody-mediated protection study, has begun here mainly in Durban first, and in sub-Saharan Africa as well as the Americas. And currently there are about 300 people globally that have already enrolled in that study. And just to remind our viewers, that study is taking VRCO1 and essentially infusing that antibody once every 8 weeks and looking and seeing if the antibody can prevent HIV acquisition.
On that vaccine trial, what would you consider a success?
So the trial is powered to see a 50% effectiveness, 50% efficacy. Then it's powered then also just have a lower bound of 25%. 50% or greater, it looks like the South African government might be willing to license it and move it forward into.
Because it's additional to whatever else.
Exactly. That's a really important point, Fred. Is we're all about the prevention package. So keeping in mind that we already have adult medical male circumcision here. We already have beginning the rollout of pre-exposure prophylaxis. We already have condoms. We already have education. So a vaccine on top of that will just continue.
It's additive.
Continue to be additive and hopefully synergistic and push the epidemic further and further into retreat.
That would be success.
It would be success.
So, do you have anything to speak to on PrEP? Or?
So yes, I do.
I mean, it's rolling it out.
So with pre-exposure prophylaxis, it has to be two tracks. It's first implement what we have, and then build the next generation. And so at this meeting, there's also been some discussions about injectable PrEP in the form of cabotegravir. And that is currently under evaluation in phase 2A early studies to look at safety first in both men and women, with a goal toward initiating licensure trials on injectable cabotegravir within the next year. So that's all moving in a very interesting way as well. So we remain excited, interested, and hopeful that we will, within a fairly short period of time, have PrEP that essentially can be given once every 2 months.
This will be for ongoing. I know some people that think their seasons of love, as the bookbinder said, or sex, or whatever you want to call it, was good for people that would use it intermittently. But this would be for ongoing use.
This would be for ongoing use, and I think that's part of the the conundrum we're trying to figure out is because it's long acting, it also sticks around a long time. That's both good and bad, or good and not so good. So we just have to, as we explore the space and how these kinds of agents are used, we'll learn a lot more.
And it will also be on where we would apply it in certain African settings, or
So it'll be very interesting to see where this kind of a product would be ultimately implemented. But first we have to demonstrate that it actually works.
So are there any demonstration projects in the wind right now?
No, it's all first just fundamental proof of concept trials, getting us to licensure first, and then we'll worry about the next step of rollout. But first we have to prove activity.
Right. Anything else you want to toss in there?
Well, I think the broad neutralizing antibodies are a potential down the road. As we begin to generate data on longer half-life of those antibodies, they also will approach 3 to 6 months. So you could have a cocktail of antibodies, as Dr. Fauci laid out in his presentation, of an injection of an antibody that would give you a level of protection that could last 3 to 6 months. So I think we're going to see the next revolution in therapy and in prevention of injectables and implantables.
Okay. Well, thank you very much. I appreciate your help in getting out the important material that's coming out of this conference.
Thank you. It's a pleasure to see you.
Thank you.